nurses, also social workers, who had been working on equity in the workplace or were inspired to work on equity in the workplace because of their own experiences or experiences of their teammates. There's quite a bit of literature on sort of the hierarchy of medicine, that is still very male-dominated regarding leadership. And we've written, one of the huge positives that has come out of the last few years and getting to know other women and men in leadership who are highly competent that are trying to change the culture of medicine is, I've had the opportunity to write a few articles. We just had an article come out in Harvard Business Review last month about good guys, and that we need to stop, quote, protecting good guys, and that it's this explain away phrase to cover up bad behavior and to gaslight women. And again, every single person that I had read the piece, men, women, and we know that, gender is not binary, men and women, as well as every industry friend, even non-friends.
I don't know how to balance that. I feel like I have a lot of people who are really upfront, and there's this larger group of people, whether that be in mental health or women who are they don't want to draw attention to themselves, which is sad, but also valid.
If I may, I want to spin this to what can we do? Because I think a lot of people are like, we hear the stories, we know the numbers are not great, what can we do? And I think, I was amazed when I first started getting, after moving out of knowing all the ultrasound literature, as we like to say by heart, and moving into the equity literature, there's so much data and numbers. I had no idea that it wasn't just my sense of things. It wasn't just my notion. It was real and it was founded, which goes back to the why, like if you're having the experience, you're not alone. If your industry is having the experience, there's probably data. And so there's some things that I think do have the ability to help change the culture and make things better. One is something called upstanding, which Reshma Jagsi, it was one of the authors on this piece in the New England Journal of Medicine. And the concept, people are like, what's upstanding? Well, if you think about bystanding, just standing by when you witness, upstanding is actually speaking up and reacting in the moment. Now, one of the challenges is a lot of times we're so caught off guard and so shocked and so like, wait a minute, did that really happen? No, we don't know what to do. So sort of educating and training people to upstand in the moment, to call things out. Another thing which is so simple, but is rarely seen, in my experience, I'd love to know your two experience, is term limits. And meaning, Reshma also wrote about this in the New England Journal of Medicine with co-authors. The Mayo Clinic has 10 best practices about why the Mayo Clinic is such a successful medical institution. And one is they have term limits. You can only be the chair for 4 years and you can get renewed once. So your term is going to be 8 years. And then there's a turnover. So say you're having a great experience as a leader. Well, you can ride that experience for about 8 years, but then you have to move to the next position, move out, and it's just known. And it's across the institution, term limits. I've worked at many institutions where there are no term limits, and there are people in leadership
I've never seen it.
20, 30, 40 years. And guess what? It's a problem. And it makes leadership look homogeneously the same as it's always been. And I think that particularly puts a halt to our changing the culture.
Just for the record, I love the way this has gone, because my question for you was going to be, with all of your focus on design thinking and designing healthcare, how can we apply that to these problems that we're having, which is basically what we're doing.
Your question is spot on. So I recently spoke with a designer, and she gave a quote that I'm going to use right here. It's, you have to live the problem to design the solution. I think what happens is that's why men think that women need to solve this. This is sort of like a tax placed on women to figure out and solve, or that we need to fix ourselves as opposed to fixing the problem, fixing the institution, fixing the culture.
It's interesting to watch women and how they treat other women in those experiences, because some of the people, and this is usually in areas that are more sexist, I'll say, it's like they want to avoid being seen to be associated with that, because they're putting themselves at risk. And I wonder how we help people like find that confidence, because you were saying like it does have personal cost. Like once you're in that category where you can't hide anymore, you can either go all out or just kind of try to disappear from, whether that be academia or the workforce. But what about the people standing by? Like, do you think it's the responsibility of those people who are sort of in the limelight, or do you feel like we're doing enough?
I think leaders need to speak up and start creating psychologically safe environments. I just came from a conference in Madison, Wisconsin, and I was part of the organizing committee, but these ideas didn't come from Resa necessarily. Resa talks about Resa in third person sometimes.
I also think it's important, similar to maternity leave, that these are expected and inquired about, not just by women, but by men or of any gender, to say, no, this is important. You know, I don't want to speak on this panel if it's just going to be men or if it's not diverse, you know, and in a similar way, ask about paternity leave when you are looking for a job. So it's not just women who are asking about these things. I remember what I was going to say before, Resa, was as you were talking about the burden being placed on the tax of experiencing the problem and having to fix the problem and how that ends up panning out. My initial reaction was, yeah, you know, I think that's part of why, you know, physician-made innovation or clinician-made innovation is so effective, because we know the problem we're trying to solve. But then in the same exact way as you were describing how it shouldn't be just on women or minorities to fix the problems that they're experiencing because it's a larger institution. And guess what? They're not in the leadership positions to make those decisions. I see the same exact thing with clinicians in healthcare in general, right? When we think about there's a lot of things leading to clinician frustration and burnout and mass exodus. There are a lot of things that clinicians can identify and know can make things better, but we're not given the agency to choose them. And those decisions are in the hands of other people whose priorities just aren't the same. At the Women in Medicine conference, I heard an explanation of moral injury, which finally resonated with me because I was really struggling with what's the difference between injury and burnout, and so I just wasn't getting it. But Jessie Gold said it this way, and she said, moral injury is when you know what the right thing is to do, or you know how to make something better, but you're not allowed to do it, and you're not given the choice to even do it. And I think that's so true. You know, whether it's speaking up for someone or being able to speak up for someone who is experiencing something that shouldn't be happening in the workplace, or it's preventing an unsafe practice in clinical care that you know could be prevented through a better process, through a better tool, through a better whatever, but the administration is like, yeah, it's not a priority for us right now. It's interesting how those themes play out in so many different cross sections of the industry.
Who helped you? Like, who helped you? And like, what made you decide you could do this? Because you're saying like, I didn't know, but I always knew I would be a physician. Like, do you think that's something you had inside, or like, did people help you?
I do think it was something that was always in me, but I definitely had scenarios where I wondered if, can I do this? Can I do this? And I kind of used to have this little, discussion with myself. Well, let's see if I do well on the pre-med classes. Okay, I did well in the pre-med classes. Well, let's see if, I get interviews. I got some interviews. It was sort of a little bit of that, but 100% along the way, I find, Fred Rogers talks about finding your helpers. 100% I had helpers. And those helpers often were not in medicine, and some certainly were in medicine. It's my best friend from childhood, Trish. It's one of my best friends from college, Anise. Neither of whom are actually in medicine. However, they know me and or they're in the working world. It's, my ally, Everett. It's who basically, gave me sort of how he navigated medicine as a black man with an accent because he was grew up in Jamaica. And so, every once in a while you connect with people and then you carry them and they carry you with them for life, and they sort of give you input that is trusted input. So I love, you've probably read the articles about your personal board of directors. I totally have my personal board of directors, call in case of. And, it's important to keep those people close so that you can speak to them, so you can debrief with them, so you can run scenarios by them. And, you know that they're going to give you thoughtful, loving input on how you should help navigate. Ultimately, you have to navigate. But I think it was there was support and navigation tools and navigation people along the way that I continued. One more person that I want to mention. At one point, I was, not even a designated instructor when I was working in New York City. And I was saying, now, I really don't care about, becoming an assistant or associate or getting an academic appointment. And part of it was where I was working didn't have a direct affiliation with a med school. It was an indirect affiliation. And my friend Marina looked at me. She said, I don't want to ever hear you say that again. Of course you should do that. You need to apply and you should be concerned. If you're going to be doing this thing called academic medicine, you need to work on promotion. One thing I want to just make sure I share is when I was recruited in 2017 to Jefferson, I was the first woman professor of emergency medicine. And I don't bring that to be like, oh, Resa's a full professor, but a little bit of, it was 2017 and I was the first woman. And compared to other academic centers, there were women already who were full professors. So there are many institutions that are struggling, working, trying to figure out how to do this. And to be clear, now it's 2022 and I am not the only woman full professor. There are more. But, a lot of institutions are figuring out how to really achieve that equity in the workplace.
The other thing I think is really helpful is on your board of directors, your personal board of directors, having people who are not in your same industry. In the same industry is helpful because then they also know how things work. But now being in the business world, I have learned so many things that I never was even remotely exposed to in medicine. And others have, I never was. But it's really made me look differently about a lot of really essential things about how you employ people, how you take care of people, how you work as a team, how you think about, budgeting and making the case for new initiatives, which I don't think we learn enough of it all in medicine, and we really need to bake into medical education. But the more I learn from people in other industries, the more I feel like I can apply it to medicine.
And that comes full circle to the beginning of our conversation where I was talking about if it's happening in our industry, it's happening in another industry. If it's happening and applicable to another industry, it's probably applicable to our industry, which is one reason why I really love Harvard Business Review articles on leadership and people management and navigating the workplace, because people think it doesn't apply to healthcare and medicine, and it usually does.
Totally does.
Yeah, it does. But I'm really glad that you were able to share both your story and ideas for things people can do, because people want something to do.
I think so. I think there is a time and a place to share the stories and get it off your chest, or just, have shared community. But, we have to decide, are we in it to do something, or are we in it to wallow? And I think there's a time and a place for wallowing, eating some chocolate, taking a walk, and also then game on, let's go.
Well, this was a great conversation, Resa. I really love the action items that you gave us because they're very applicable, as you said, to every person in every industry and probably every setting. And I certainly learned a lot, and I look forward to sharing and looking at some of these references that you gave us.
Thank you. Thank you so much for the invitation.